I'm Dr. Namra Sheikh. I'm associated as medical advisor with Emcure Pharmaceuticals Limited. I welcome you all to on this digital platform for another exciting session on No Thrombosis workshop series on acute ischemic stroke. It gives me immense pleasure to introduce our course director for today's section, who is Dr. Subhash Kaul sir. Sir is senior consultant and stroke specialist at KIMS Foundation, Sikandarabad. Sir has been the faculty for over 27 years in the Nizam's Institute of Medical Sciences, Hyderabad. Sir has been a former HOD and head of Department of Neurology and Dean at NIMS. Sir has the credit of over 120 publications in national and international journals. He has also been principal investigator or co-investigator at several national and international projects, including Hyderabad Stroke Registry funded by ICMR. Sir has been past president of AP Neuroscientists Association, Indian Stroke Association, and Indian Academy of Neurology. It gives me immense pleasure to welcome you, sir, today. Thank you for being on board.
Thank you. Thank you very much. Thank you. Thank you.
I would now go ahead and like to introduce our moderator for today's session, who is Dr. Mangesh Adhar, sir. He is working as a consultant neurologist and DNB neurology guide at Sahyadri Super Speciality Hospital, Pune. Having of more than 15 years experience as a practicing neurologist in the field of neurology, Sir is also working as a consultant neurologist at various super speciality hospitals. He is a secretary of the NSP, which is Neurological Society of Pune, and holds special interest in stroke, vertigo, and epilepsy. I welcome you, sir. Thank you so much for being on board. I would now like to introduce Dr. P. Vijaya, ma'am. So, ma'am is the moderator for today's session, the second moderator. She is been working as a senior consultant and head of department at Lalita Super Speciality Hospital, Gantur. She has a credit of experience of three and a half years in neurology. Ma'am has started the first stroke unit in Andhra Pradesh, pioneered in IVT and interventional stroke therapies, and developed it into a first certified advanced stroke center in India. She is the executive member of ISA. She has a credit of presenting papers at national conferences and international conferences like WCN, WSO,
Thank you so
international.
much. That's, I think we'll just, this is not very, I was not asked. Brief one is enough. Thank you.
Oh, all right. It is a great. She's also worked as a principal investigator for various prestigious trials, and we welcome you, ma'am. Thank you for being on board. It's a
Thank you.
pleasure to have you today.
Thank you. Thank you.
Today we have eminent speakers who will be delivering talks on difficult cases which are encountered in clinical practice. So our first speaker for today's session is Dr. Vishal Patel. Sir is a consultant neurophysician at Gayatri Neuroclinic, Patan, Gujarat. He is working as a senior resident in the Department of Neurology at National Institute of Mental Health and Neurosciences, NIMHANS. His core expertise and primary responsibilities include patient care and teaching the external PGs. He is trained in performing nerve conduction studies, EMG, RNS, and reporting EEG, and has reported more than 200 such studies. He is proficient in stroke, epilepsy, neuroinfection, headache syndromes, vertigo, dementia, movement disorders, neurodegenerative disorders, neuropathic disorders, and demyelinating disorders, to name a few. We welcome you, Dr. Vishal Patel. Thank you for being on board.
అవి ఒక గంట నేను బిజీ ఉన్నానమ్మా అక్కడ 5 మార్నింగ్.
Our next speaker is Dr. Venkatesh Bolgave. Sir is working as a consultant neurologist at Nectar Hospital, Sane. Has a credit of multiple publications in various journals, has presented papers and posters at various conferences. To name a few, the National Conference of Headache Coaching, where he won the first prize and third prize in the National Neurology Quiz at Shine Conference, Chennai. He has conducted several quiz competitions for neurologists at AOMC International Conference, Mumbai. We welcome you, sir. And without further ado, I would like to I would request Dr. Subhash Kaul sir to continue the session.
So, welcome everybody, and thank you, Namara Sheikh, for starting the proceedings. I welcome the moderators, Dr. Vijay and Dr. Mangesh, and today's speakers, Vishal and Venkatesh. So, as you know that this is a case-based session, which is held every month. And highlight of this is that usually those cases are discussed where there are no clear-cut guidelines, and we practically learn from the situations which come difficult situations and how the particular doctor faced the problems, then how he managed it. Sometimes we agree, sometimes we disagree, but finally we learn from all this. So our moderators are very eminent. Dr. Vijaya is my friend and classmate of probably 30 years now in duration. And Dr. Mangesh is a new friend. So can I hand you over and please invite the speakers to give their to make their presentations, and after each end of each presentation, we'll have some discussion. Please go ahead. Dr. Vijaya, you can start.
Yeah, I think it's always every stroke is fresh and every stroke is a challenge, even despite our most senior people. So it will be interesting to hear what they say and then we can discuss. I think we can have the first speaker start his case. Namra?
Absolutely. Dr.
Yeah.
Vishal, can we go ahead with your case discussion?
Whoever is ready, I think we can hear them.
Namra, can you allow me to share my screen?
Absolutely, just a bit. You can now share your screen. I've stopped sharing.
Okay. Somehow I'm not able to share my screen.
Please make it, yeah, great. That's fine.
Okay.
Uh, Good evening, respected teachers. I am presenting one interesting case of ischemic stroke. Uh, he is a 49 years old gentleman, right-handed. He was illiterate and farmer by occupation from Dharwadi village, which is around 1.5 hour distance from Patan. Actually, I am practicing in a second tier city. It is a town place and a district place. This patient had a no comorbidity and apart from daily tobacco chewing, he had no other addiction. Next slide. So he was presented with a history of sudden onset of the weakness of the left upper limb and lower limb in the form of not able to move left upper limb and lower limb at all. So I actually modified these slides. He went to around 9 o'clock to the farm and he started watering the crops. And around 10 o'clock, he met his some neighbor farmer and he had a normal conversation with him. Around 1 hour after 11 o'clock, he had sudden onset of the weakness in the left upper limb and lower limb. So he was being referred to the general practitioner, and later he was being referred to me around 1 o'clock. So from the onset was not clear. The patient was really illiterate, and finally I found that around 11 o'clock the onset was there, and he reached my clinic at 1 p.m. So that was approximately 2 hours of the onset of the symptoms. However, still I had a confusion with the onset. So I checked clinically. His vitals, his pulse was 112 per minute, which was irregular. His blood pressure was 104 by 64 millimeter of mercury. His blood sugar was 84 and ECG suggestive of atrial fibrillation. So around 20 minutes after he reached to the OPD, brain MRI was done and NIHS was assessed in the clinic only. So he had a dense hemiplegia. Left upper limb score was 4, lower limb was 4. This is the left facial paresis was 3, and he had a significant dysarthria. Next slide. So first MRI brain was done because onset was not clear. So first four slide, there is a posterior circulation, right cerebellum, dense hyperintensity is there. And in the vermis, there is a small hyperintensity. I cannot arrow, but and in the anterior circulation also you can see there is a uh, uh, there is a right caudate nucleus and right lentiform nucleus. Hyperintensity is there in the diffusion. Restriction is there, but it is not as hyperintense as in posterior circulation. And there is a patchy restriction is there in the bilateral parietal cortex also. So there is a multiple territorial involvement with different duration. Next slide. So to confirm, uh, in the posterior circulation, in the flare sequence, axial flare sequence, we can see there is a hyperintensity in the right cerebellum itself. But if we see in the anterior circulation, what we had found in the diffusion restriction in the right caudate and lentiform nucleus, here we cannot found. So in the posterior circulation, both flare and diffusion, there is a hyperintensity, and in the anterior circulation, there is a clear-cut mismatch is there. So this patient had both anterior and posterior circulation infract, and more involvement is the right side. Very patchy infracts are there in the left parietal also. Next slide. So after the MRI, around 6:45 p.m., patient was thrombolized. That is around 2 hours and 45 minutes after the onset. He was being thrombolized with tenecteplase 4 milligram, and post thrombolysis, he was significantly improved, and his NIHSS was 2. So asymmetry and uh, mild dysarthria was there. Day 2, there was no bleed, and at the time of the discharge, his NIHSS was 0. So patient is completely improved. Patient came from the very small village. They didn't understand that, they don't know about the injection also. So he was so happy, and now these controversies are this different territory bleed, and that posterior circulation, we can consider it is a recent infarct. So, and this anterior circulation, it was sudden, that day infarct within 4.5 hours, and yet we thrombolized, and aspect was also favorable for the thrombolysis, both for anterior circulation and posterior circulation. Thank you. Next slide. Okay.
You finished, Dr. Vishal?
Yes, ma'am.
Okay, good. This is a very good index case. The usual controversy, whether to thrombolyze. Okay, first Dr. Kaul. Dr. Kaul.
No, I just want to know, his CT scan was done or only the MRI was done?
First day, while patient came to clinic, still I have doubt. He was illiterate, and the persons who accompany with him, they are not really sure about onset. So I have done directly MRI rather than taking the more and more time for the history. So
Okay.
straightforward, I did MRI and screening for flare and diffusion.
And the previous MRI, the previous stroke which is seen on the MRI was
completely asymptomatic.
Was silent. Yeah.
Was silent, yes, sir.
Yeah. So yeah, I mean, we don't know when that stroke has occurred, and I think that is the interesting thing about this patient. Normally, we say that if there's a previous stroke in the last 3 months, it's a contraindication. And in fact, it is such a contraindication which has not been modified. Most of the contraindications have been modified. Most of the contraindications, single antiplatelet, double antiplatelet, heparin, everything has been modified. But what has not been modified is this past stroke. But we know that many times those patients don't bleed. But it is just that contraindication stands there. But many times they don't bleed. So I think this is a good, good kind of observation that even though the patient has had previous stroke, yet he did so well and he didn't bleed. I mean, it's interesting. Vijay and Dr. Mangesh, you can give your opinions.
Yes, I think that is one of the contraindications which we do follow. And I think was an angio done. I think the new infarct looks like it's a 3-territory infarct. It's a posterior circulation as well as bilateral anterior circulation. Was there any
Angio are completely normal.
Angio was normal, and 2D echo?
CT angio was done, and 2D echo was done. Trans esophageal TE was not done, as this is a second tier CT. So some of the advanced investigation was not being investigation. Patient was farmer and having financial issues also.
And the ECG did not show any arrhythmias.
Atrial fibrillation.
Atrial fibrillation. So, Madam?
So many, the jury is divided. It's always whether to give or not in this situation, but you have chosen correctly in view of the age, and most important thing I feel is the golden hour. If they come very early after the onset of stroke, you said 2 hours at least, and if the patient is young and BP is not high, we can still take the risk of bleed and give thrombolysis. I agree with that part. However, there are some studies which showed efficacy is equal, but the risk of hemorrhage is higher in these patients with atrial fibrillation treated with IVT. So what are the parameters we take to assess that risk is still not very clearly elucidated. The previous one point Dr. Kaul has taken is the past stroke. Even though it is silent, it is in a very important area of posterior circulation, and it's very relevant. Again, there is a controversy there whether to give or not, but the decision is on the clinician to assess the risk-benefit ratio. Always, if the stroke is high NIH score, you should go ahead and give. That's what I feel. It is based on our
I have
NIH.
a limited experience in implants. What I found, what I observed that cardioembolic stroke, they are the best responded with IVT. This is my limited experience, and I had seen so many young patients who have a cardioembolic stroke, and they are dramatic improvement with thrombolysis. So here I thought benefit is more. And this posterior circulation, what I had found is that right cerebellum some patchy embolic infarct. So what I was thinking in my mind that risk of the bleed may be less, and there is no restriction in the pons or cerebellum. Even though we can calculate the aspect if the posterior circulation, that was also one or two, one only I think, right cerebellum only. So that is the thing. After that, I just thrombolized.
No, there is a lot of papers written on this. In fact, in Japan, if you see Japanese guidelines, they have not kept this 3-month restriction. They have kept 1-month restriction. So in Japan, if the stroke has happened within 1 month, then you cannot thrombolize. But if it has happened before 1 month, then you can thrombolize. But in US guidelines, they have not revised that 3 months thing. And but there are many papers which say that if the infarct is small, for instance, what is the size of the previous infarct? If the size of the previous infarct is like a lacunar stroke, then probably he is not as much risk. The risk is of bleeding. That is what, because they say once there's an infarct, that much of the part is little friable, little soft, little fragile. So it might bleed. That is the risk. That's why they are. So I also, for many years, I followed that until in 1 or 2 patients like yours, we gave thrombolysis and nothing happened, which emboldened me a lot. Till one of my patients had a massive bleed. And after that, I stopped again. I said that, you see, there is a lot of heterogeneity in these patients. These guidelines are not God lines. God has not said that you should not give it. It is based on collective experience. In that, some will do well, some will not do well. Probably most of the guidelines are made for safety rather than efficacy. They are made for safety. But the cases like yours tell us a lot. They tell us that necessarily they may not bleed. They may do extremely well. Now imagine if you had not thrombolized this patient, you would have left with the disability. So as Vijaya said, that sometimes we have to take a talking to the patients, attendants. But of course, the knowledge of the literature is very important. Guidelines is okay, but finally the knowledge of literature also is very important. For instance, I know that there are case reports, like you should publish this as a case report, so that the clinician knows that, no, there are cases who may not bleed. Most of the patients will not bleed actually. A very small proportion may bleed, maybe those which are bigger and all. I think you also took that thing into consideration, what you were just now saying, that you thought that the old infarcts were very small. They had a less chance of bleeding. But as per guidelines, you have broken the guidelines. But as they say, only those who know the guidelines are allowed to break the guidelines.
Actually, after this thrombolize, I read the Continuum article, and it was removed, I think. This 2019, I think they updated. So what was the previous infarct within 3 months? In the Continuum article, it was written. Now it is removed.
So what is now? There is no previous stroke is not a contraindication now.
What I read, sir,
it is not an absolute contraindication. Not an absolute contraindication.
But that time I don't know about it.
Chalo,
and what did you start for secondary prophylaxis? That is even more important.
So,
already 2 strokes. When did you start?
So he was from a village. I thought he will not monitor the INR properly. So I started Novak, dabigatran, 150 mg twice a day. So now patient is having no recurrence of the stroke and patient is stable.
I was
Good.
actually, why I asked you, have you done the CT scan or not? Because I would be interested in knowing whether the CT scan showed that old stroke or not. You know, most of these guidelines and data, it is based on, it's a CT based data. So it is by and large, in MRI gives you a lot of information and some of the information which we don't need, and it confuses us, you know, like microbleeds, like flare changes, which CT scan doesn't show. And most of these thrombolytic trials were done on CT scans. So that's why I was asking you, have you done the CT scan? If CT scan would not have shown the old infarcts, we would not even be bothered about it.
Yes.
Yeah.
Sir.
Yeah. Okay. Any other point, Vijay?
No, I think every patient deserves a chance. That's the message, I think. And we should be bold enough, especially if he was young and a high NIH score. And what do you think about this direct thrombectomy, Dr. Kaul and Dr. Mangesh? If the patient had LVO and he was affordable, what do you want to do? Whether you want to bridge or you want to go for direct thrombectomy? If there
Dr.
was
Mangesh, Dr.
Yes.
Mangesh, what would you do?
So within the this thing, if the clot load was high, if it angio should definitely have helped me if it was done prior, and if it was a stroke which was LVO, then I think a direct thrombectomy was probably a better option than doing or bridging also. Bridging might have been more helpful rather than just intravenous thrombectomy. But in that setting of tier 2 city, I think that was the best judgment for him.
Yes, yes, yes. As of now, both things are okay, but the weight of the evidence and the guidelines are supporting bridging. That means if the patient is within 4.5 hours, then you should do IV first and after that mechanical. But in given situations, you can skip it. Here we would have skipped it because we
Yes.
were afraid of that. Yeah.
Yes, sir. In this particular atrial
Yeah.
fibrillation
Yeah.
with already some infarct,
Yeah.
so maybe if there was a hypothetical situation, but still I would also go for direct
Yeah.
trauma.
Yeah. Correct. So thank you. Great case. Great case. A lot of learning. Yeah.
Thank you, sir.
Thank you. But you should publish this. You should publish it.
Okay.
No, nobody is going to accept it, but keep on trying. There are many journals, you know, because I know the reviewers. They will immediately say, no, how can you say that? But still keep on trying. There are hundreds of journals. Publish it somewhere so that it will come in Google and people will learn it. You know, normally whenever we have to do anything, what do we say? Check Google, check Google. So we should be ourselves also writers rather than reading others' experiences. So please write it.
Sure, sir. I will try.
Yeah, Vijaya.
Thank you, Dr. Vishal. It's a good case for discussion.
Thank you, ma'am.
Now I think we can invite the second speaker.
Yeah.
Is he ready?
Venkatesh?
Yes.
Yeah, you can share your screen.
So, yes. Good evening, all. Are you able to see my screen clearly, sir?
Yes.
Yeah. And voice is okay?
Perfect.
Perfect. Okay. So, thanks for the opportunity. So, I'll be starting with the case. So, this was a 27-year-old gentleman who presented with acute right hemiparesis and dysarthria. It was in June 2023. He had no history. He was out of window period. He had no history of hypertension, diabetes. There was no use of tobacco in any form, and family history was not contributory. Clinical examination, as he was young, there was forehead baldness, but it was familial. There was no scoliosis, no angiokeratoma, and fundus was normal. So he was imaged. This was MRI brain and angio, and we can see that there is left MCA infarct, which was patchy. There was no GRE blooming. And angio wise, major vessels were normal. We can see ICA and even the MCA M1 part terminal M, we can see it clearly on both the sides, on pathological side. But the terminal branches on the left side seems little, there was paucity. So as there was no major vessel occlusion, he was worked up for the cause, and routine etiological workup was normal, including blood sugars, HbA1c, lipid profile, homocysteine, and triple H. So further workup was done. Thrombophilia workup was negative. Vasculitic workup was also came negative. His cardiac workup was thoroughly done, and it was also termed it was also normal. Even serum lactate pyruvate was normal. So with this background and workup, patient was put on dual antiplatelet, statins, and multivitamin, and then he was followed up. After about 2 months, he was traveling, and in that time again he had slurred speech. And since he was traveling, he could not reach the hospital immediately. And this was at night where the event was happened. And in the morning, then he came to the hospital. So he was obviously again second time out of window period. After the first episode, he was told if recurrence occurs, he should be within window period to the any major center with stroke facility. So the thing was, this was just for discussion. These two medications, we will discuss it after the case. So even though patient was compliant with the treatment and there was no obvious risk factors, and still he had stroke in the same territory. So the test was sent for clopidogrel resistance because it is now available. Again, the importance of this we should be discussing. And we found out that there was some mutation which suggests that poor metabolism clopidogrel. So the indication was to start another antiplatelet like prasugrel or ticagrelor or in place. Again, with so much of workup, whether we should start anticoagulation, etc., was discussed. But according to these two studies that Navigate ESUS and Respect trials, patient was to be kept on dual antiplatelets rather than anticoagulation. Then he was because of recurrence of stroke, the DSA was advised and it was done. So you can see this is on the right side. The vessels looks good. There was no obvious any stenosis occlusion we can see. And this is on left side, and we can see that there are some areas here, where paucity of there is some stenosis occlusion which is seen. So on the left side, we can see multiple areas which are not filled very well. So with this and the workup, we further evaluated the patient. Even vessel was imaging done, but we could not find out any wall enhancement, etc. And the possibility they have raised was embolic stenosis, tiny occlusive disease in the distal left vessels. So the treatment was changed and ticagrelor was introduced. So he was doing well, but after again 2 months into the illness, he had stroke. Now he had disabling weakness, and he was within window period. So now patient had 2 strokes, even on dual antiplatelets. After changing antiplatelets, patient had stroke, and now he is within window period and with disabling stroke. So that is the thing again, that same point again comes, whether to be thrombolized with previous history and within 3 months of the stroke. And as we discussed, there are no obvious guidelines, and out of benefit to the patient, like in this case, I had gone ahead and explained them very well. And since this was disabling young guy, I went with thrombolysis. So he was thrombolized 10 hectoplasm, the usual dose, and luckily he did well. But since he was there was recurrent stroke even on dual antiplatelets, and even though workup was negative and there was no obvious any other option remaining, it was discussed with colleagues and he was put on anticoagulation and planned for further workup. And I don't know what was the bad luck. he again came with a new stroke next time. He was obviously, this was not too disabling, and that's why he was not given any acute management for the same, because again he was within 3 months of the illness. A repeat DSA was done to see, because he had already disease which was shown, which was multifocal. And here we can see that disease has progressed actually. So even patient was being managed on antiplatelets, anticoagulation, and even statins full dose. The disease has worsened. So you can see here the vessel is now again patchy involvement, and almost there is significant worsening of the disease. So now with this recurrence, stroke, etc., the diagnosis further evaluation wise was to do CSF and rule out other things. So CSF study was done, which was normal, cells were normal. Varicella zoster was evaluated, which came negative. So this is a young guy with recurrent strokes. Even was thrombolized, and even with addition of antiplatelets and anticoagulation, still he had failed to all these medical management. So now suspicion of some inflammatory process was there, and patient was put on steroids and followed by cyclophosphamide. Further investigations are planned in the form of biopsy. They were advised, but they have denied biopsy in the last admission. PET scan is planned now, and even after that cardiac MRIs they have been told. So this is a case with who is young male with recurrence on treatment. The territory involved is left hemisphere only. Even background suspicion of vasculitis, etc., thrombolysis was attempted, which was a high risk, and till now there is negative workup. So further we need further investigation and management. So since we had put patient on steroids and cyclophosphamide, we've gone through the literature to see, because in this case 4 times similar, the same hemisphere has involved. So we've gone through the literature, and we have found that there are cases in which the recurrent events were on the same hemisphere. So there is literature on that. Even workup wise, we have found that in this study they have worked up around 3,500 patients, but only few patients they could find out the etiology in form of vasculitis. So the workup can be negative many times in many patients. And what is if we are suspecting vasculitis, etc., how safe is the thrombolysis in such cases if they are presenting, whether it's involves CNS or any other system? So they have said that the hemorrhage chance in such cases is high. So we have to be careful in such cases when we are suspecting vasculitis and thrombolysis is planned. And this is again the same case where thrombolysis is to be attempted or not. Thank you. So that was the case. So open for discussion with the points I highlighted.
In case I missed, that's a very good and another very interesting case, doctor. Did we have an MRI with microblades, JR?
No, there was no microbleed, madam.
No microblades.
No. So I had to show.
Okay, what was the LDL? Can you just elaborate more on the lipid profile? What was the LDL?
It was normal, sir. It was done 3 times, sir. 3 or 4 times. Okay. It was normal. Even homocysteine, it was checked 5 times. It was never more than 50.
Okay.
And he was throughout the treatment time, he was on B12 supplement.
So Venkatesh, yeah, please. Yeah,
sir,
Dr. Mangesh.
Sir,
Mangesh.
Yes, to you, sir. First, you story.
No, my question is, you thrombolized the 3rd stroke.
Yes, sir.
But why didn't you thrombolize the 4th one also? What discouraged you?
Right, sir. Again, sir, he was almost within 1 month again, he had stroke. He was the antiplatelet was high. The disability was less, sir. This time he was able to walk. So if we see the risk, etc., he was told that there is high risk of bleed. He might or might not. Since the disability was less, it was not thrombolized basically. He
Dr.
was walking.
Mangesh, Dr. Mangesh, please.
Yes, I was just thinking there was no evidence of vasculitis on the DSA, means no bleeding, nothing, and only the paucity of vessels. So other vasculitic workup would have helped P Anka, C Anka,
Yes,
A in
yes.
blood.
Done, sir. No, normal. It was done after first event only.
Okay, all were normal.
Yes, yes.
So, what I would have, I mean, the only thing which I was thinking, if I were you, being a young person and high suspicion of non-atherosclerotic stroke, I would have gone for anticoagulants in the first place itself as secondary prophylaxis. That is one thing. Second thing is I would like to repeat all these Priyanka, Siyanka and other vasculitis workup if it was feasible. Second. Third thing is immunomodulation. We should these days, I think we should be having, if we are ruled out all other obvious pathologies, we will have a very low threshold to our rituximab or cyclophosphamide. You have done very well that part, but maybe after second stroke or so we could have thought about it or discussed about it. CSF was done, you said, no?
Yes, it was done.
Yes.
It was normal.
Okay, this is like PCA is also there, though MCA is the most, if at all, abnormal vessels.
Yes.
One impact there is in the PCA also, no? Was there?
Yes, there was.
It was. Okay. The vessel wall imaging was done in 3 Tesla?
Yes, 3 Tesla.
Did not contribute any information.
No, did not contribute.
Okay.
But this DSA which you are showing, the DSA which you are showing, and with the arrows you are showing some discontinuity of the vessels. Yes. What does that mean?
There is some stenosis, sir.
And what is the etiology of that stenosis?
That is the thing, sir. We don't know. But
obviously it has to be a vasculitis only, no?
Yes.
What else it can be there? What other pattern? It is a vasculopathy, let us say.
True.
So if it is a vasculopathy, then etiology can be anything of that. But what we can say is that definitely you can see here, it's seen that this is very irregular lumen and ragged and jagged vessels and discontinuity. So some disease process is hitting the vessels. It's a vasculopathy for sure. And it's an active vasculopathy because he's having strokes after strokes after. It is burning. It's a burning endothelium, which is not being extinguished. So, as Vijaya says, you could blindly have given anti-inflammatory, I would say. Not that that's a proof of it. Ideally, this patient should have a biopsy, which you are planning now.
Biopsy. Right? Yes.
These are very difficult patients. And this vessel wall imaging, no, it is not still evolved to perfection as of now also. If you look at the data of the vessel wall imaging, there are many false positives and false negatives in this vessel wall. It can still miss the small vessels and the narrow vessels. Yeah. So, but going overall picture, clinical picture, first of all, youth of the young, age of the patient, no other risk factors, strokes after strokes, and this vasculitis is clearly some inflammatory vasculopathy. Of course, everything is not present. CSF should, one of the important things is CSF, but then CSF may not be positive in 100%. It may be positive in 90%.
Yes.
Our patient may be in those 5-10% where CSF is not contributing. So I think I would not hesitate in you giving this patient steroids and then those rituximab and all that thing in the faith that it may work. Of course, we have no proof, but what else it can be? Infection is something which we have to be very careful in ruling out, but you have done varicella.
Yes.
That is the common one. We have a patient of varicella vasculitis. You have ruled it out. There are no malignant cells of lymphoma and other things which, you would have. It's no tuberculosis.
No.
That you have ruled out all that. So that leaves us by exclusion that some kind of a idiopathic inflammatory. That is what vasculitis is about. It's a difficult patient, but all of us see these patients from time to time.
Yes.
Right. One investigation which would have helped was the contrast MRI. I think if you have vasculitis and if you light up some areas, I think they would give us guidelines for doing a biopsy plus
True.
dural biopsy. Dural plus cortical biopsy, because I have got similar one patient, a very young chappy, he's still on immunomodulators. The
Yes.
same way, contrast MRI gave us some clue to do a biopsy, and it was a PCN, primary CNS vasculitis.
Yes. That was done. It was negative in this case.
Contrast MRI was
Yes.
negative.
Yes. Yes.
Mm.
So overall, the other things were, they have come up with these new things, like some are promoting like whether clopidogrel resistance test works or what is its utility. So that is the one thing. Other things, they have come up with these molecules, and many patients are even asking. So I don't know the thing to be told to them, and like experts only can tell. When I told them, ask some expert to give them or ask them, then only we can give. Otherwise, they are not in guidelines.
No, as far as the clopidogrel resistance is concerned, it's a fact, and in cardiology, there's a black box warning. Cardiologists have practically stopped using clopidogrel because there is 30 to 60% resistance is there, and obviously in neurology also there will be resistance. It's not that the cardiology is different and neurology, vessels are same everywhere. So we are also doing currently a project, and our interim results are also showing the same thing, that people who are having recurrent strokes on clopidogrel, they are having this resistance. They are poor metabolizers, so they don't work. So there is no doubt about it that ticagrelor is a better medicine than clopidogrel. There is no doubt about it. But the guidelines have not yet told us. Guidelines it gives you overall idea. We don't have to exactly slavishly follow. Guidelines are behind the whatever is the current literature. As far guidelines in neurology are not telling you not to give clopidogrel or anything. They are not even telling you to do testing. In cardiology, they are telling. In cardiology, guidelines say that before you give clopidogrel, you should test it for. It's a black box warning. So cardiologists have stopped using clopidogrel. They use only ticagrelor and prasugrel. In our case, we are still using clopidogrel, but there is no doubt that clopidogrel. But then that question is not relevant here in this case, because here we are not thinking of atherosclerosis. This clopidogrel, aspirin, they are for atherosclerotic strokes. Here we are thinking of vasculitis. So here
The
there
other
is
things was, sir, the unilaterality. So all the events were in the same territory, same hemisphere, basically.
Yeah, you are
That
right,
was
and yeah, that is odd for vasculitis, but rarely it can happen. Rarely, but it is odd. It is odd for primary angiitis of CNS.
CNS.
But if you take varicella vasculitis, it is not odd. Varicella or any post after primary angiitis, the other important cause of vasculitis in our country is viral only, and it may not be chickenpox only or varicella only. It can be any virus.
For him,
So
we had given antiviral treatment also, sir.
Yeah. I mean, I know.
We had.
So it is for primary angiitis, it's odd, but for post-viral prototype of which is varicella, it can happen. So, because see, recurrent is happening. Now, your second question is very interesting. Tyvalzi and centrivivan, I would request Dr. Vijaya only to talk on it.
I can talk about Tyvalzi because they're part of the trial also when it was done.
Yeah, I know. That's why I'm requesting you.
And actually, we randomized about 20 patients, and one patient had problem. So what I learned, the lesson from the so many clinical trials, Dr. Kaul, and is we should not combine any new drug with a old drug. For example, though it is very peculiar, I'm just telling out of my personal experience. So IV thrombolysis and a new drug, actually that's where we need them, but I never combine. So by itself, when the patients are ineligible for IV thrombolysis, they come beyond window period, I'm trying it. That's what I'm doing. So safety, as we all know, we want the safety of the patient first, later only the efficacy. It can work, but we have to wait for another couple of years to have these phase 4 studies and then decide. At least it is safe as of now.
Yeah, I completely agree with you. Both these drugs have been approved in India, DCGI, but there is not any international support as yet. They are not in European guidelines. They are not in American guidelines. So therefore, we have to wait and watch. But sometimes in stroke, when you have nothing to give, we are giving something. If we are giving something, that does not mean that it is already approved and everything. It's a kind of a blind thing. When you have nothing else to give, you are giving this thing because you have nothing else. But they are not as yet approved by the major societies. Not even the Indian DCGI is approved. That's how it's in the market. But it's not in Indian stroke guidelines as yet. So you are allowed to use it. And one thing I have all checked is the safety profile. Safety-wise, these both drugs are okay. And so it will take us few years before, when tenecteplase also came, initially we were very reluctant to give it. This tenecteplase team knows that. For about 5 years, even after it was marketed, we did not use it. Only after some more data came, some more trials came, extend came, then we were confident and we started using it. And now we are very confident. And we are, so whenever any new drug comes, there's a waiting period by which we know. So these are very new drugs, only released in India. Tenecteplase also was only released in India first. But eventually, it proves its worth because, so we have to wait for these drugs also. We are not dismissing them, but we have to wait and watch.
The other question was, sir, thrombolysis in cases of primary or secondary vasculitis with some, like you had asked to see GRE, some bleeding dots, etc. What should be done in? Because the literature says there is high risk of bleeding in such cases. Data is not available.
Literature says there is high risk of bleeding, and that is true. But it is not listed among the contraindications also. So it's your call. Even if you don't give it, you can always defend why you didn't give it, because high risk of bleeding is very well documented. One of the best examples is infective endocarditis. It's absolutely contraindicated because you are afraid of bleeding in them.
Right.
Now, vasculitis is not, but the model is almost same, no? Model is almost same. Severe inflammation of the vessels. But if you give it also, you can defend it because it's not listed as contraindication. Yeah. But that was not the case here. The case here is that in both cases, that 3-month rule has been defied.
I have so many patients I had to say.
Yeah. So that is, I think both cases were very good. We had good discussion. We learned also. With each case, it opens our windows. Now I will go back to book today and I will see whether this 3-month rule has been removed or not. I'll be very happy if it has been removed. So we have to also keep ourselves updated, no?
Unless there is a large infarct, Dr. Kaul, I think if there was a large there which is likely to bleed, it's as you said, Lacnar and little more than Lacnar, or not at all a indication. If there was a large infarct, maybe we'll also check the actual what they say in guidelines. Nice, interesting. Both are young strokes, and that is also very relevant.
Both are young strokes, and both presenters are young. So that adds to the beauty of the cases. Young stroke presentation by young neurologists. Fantastic. So Vijaya and Dr. Mangesh, if you have any other comments, otherwise we can hand over to organizers.
Yes, I think so.
Thank you. This is a very good.
Okay. So thank you very much for providing time for this meeting, and we are extremely grateful to you and thankful for all the wonderful insights that you have provided us with. I would also like to thank Dr. Venkatesh Bolgave and Dr. Vishal Patel, sir, for the cases that you have presented to us. And obviously, our moderators for today's session, Dr. Mangesh Shadar and Dr. Vijaya Patel, ma'am, for their wonderful insights. So soon will we be, should we close with the session, sir? Soon we will be meeting for another interesting case discussion. Till then, thank you everyone and good night.
Good night. Good night. Bye-bye.
Thank you. Thanks, Dr. Kaul and
thank you.
Mangesh and both the presenters. Thank you.